Welcome back to another episode of Stories and Conversations. So, this one is going to be a little bit different. The guest that I have today is quite a busy man, and I appreciate that because he's doing a lot in the healthcare space. But I really wanted him on this series, this October series. So, I'm glad to have him here. So, I will allow him to introduce himself, then we'll get right onto the conversation. So, Dr. Ryan, welcome to the show. Thank you for honoring my invite. And I know we've been trying to do this for quite a long time, but I'm glad that we're doing it now. So you can introduce yourself. And what I normally tell my guests is please feel free to share anything, personal, professional, whatever it is, for the viewers to know who you are as a person. Yeah.
Thank you very much, Rahel. It's a privilege and honor to be here. I'm really sorry for how tight the schedule has been before we have this conversation. So my name is Dr. Ryan Nyotu. I'm a father, I'm a husband, I'm a Kenyan, I'm a young scientist. I've been working in the health sector for the last since 2011, actively within the space of innovation. I like to identify myself as an adaptable scientist because my career began immediately after. It began during high school, where we started playing around with computers, early programming days, but then we used to do it for fun, we used to do it for gaming and things like that. Went after high school, we did those courses that everyone used to do after Form 4. Mine was a diploma in business IT. This is a Strathmore. I went through the course, did not do the project because I was then called to med school. I got to med school. I remember those early days, the conversation was, have you wasted money in going to try and do this ICT thing if you're going to become a doctor? Those days, ICT and medicine were not really, they were not really bedfellows back in the day. And I guess as a theme that's been recurrent all through my training. I was able to join medical school in around quite a while back, and then by 2011, I got an opportunity to do a degree within medicine, and this is, I guess, where now the match was lit, because it was an interconnected degree, a bachelor of science in medical physiology. So you do the first year as part of the course with the other people, and then the second year you do it now. You just come and you focus. So we're a very small group, and you're taken through the fundamentals of research, and you have to to attain the degree, you have to really go through a period of experimental research. So that was my first tinkering with research, computers, and the bodies. Because I remember I was assessing blood pressure in rabbits, blood pressure in rabbits, and we were testing the effects of rosemary. The rosemary tea we drink. Wanted to see, does it have really effects on the heart? Wow. So to do this project, at that time, technique was very manual. It was the old machines where you put a catheter into the rabbit, and then it measures. And it was manual, so you have to sit with a graph on paper and try to do this. So my supervisors and I, that was the late Prof. Okongo and Dr. Aweru, who's still very active within the Department of Physiology at University of Nairobi. Mm-hmm. So we decided, why don't we try and create a mechanism for this? So we had to come and take apart computers and take apart the measuring thing and see if we can connect to a computer and have it read. And it was a success, because we now even track the effect of rosemary in milliseconds. The effect of rosemary at that time was very fast. It was acting in the first 2-3 seconds. So you had to be able to break that up so you can study how the curves are going. Mm-hmm. And that was my first thing with the field with the medical engineering field. Immediately after that, I had learned research. I wanted to test if this thing we've been taught of writing proposals is a true thing. So immediately after that, a group of us, 7 young enthusiastic scientists, got together. Those of us who knew research were able to pass on the techniques for research. We wrote a proposal. The proposal was at that time it was very ambitious. We wanted to make a smart bandage. Mm-hmm. And this is 2011, and we wanted to make a smart bandage, one that responds to wound, and the target population was plastic surgery patients who are having conditions for a long time. So to do that, look for bacteria that we can genetically engineer to be able to extract the antibiotics. And in doing that, we ended up discovering that there's a bacteria which excretes a very potent antibiotic, a very broad spectrum antibiotic. And we were very excited. But when we searched for it, we discovered that it had been described in Japan, then been described in Kenya. But we had some feeling that it existed in Kenya. So this ended up being a very interesting journey where we discovered a bacteria, we named it, and then we patented all the stuff that came from it. So this was the first patent. My first patent was in 2013.
Oh wow!
And then that was a keepy one by 2015. I think if you check the records, 2015, the only WIPO, World International Patent Organization patent awarded to Kenya was for a small company called Trek Science. And those were the early days of learning how to get big projects moving. Because you see, we couldn't do it ourselves, so we had to go to Calro, then Kari, to get the bacteria, to get access to it. The professor who had done the work that described it, maybe in Kenya, was based at Calro at that time. So he helped us to learn a few of the skills. We had to partner with the CPE, and then also we had to partner with our own university because patent laws, IP laws back in the day were very tight for researchers who do research work within institutions. And from 2015 all the way to around 2020, we were battling with this project, and we took it to a pretty far stage before we left. But then that was also the spark that kind of drove me towards the field of digital health, because I discovered the challenge we have. One of the reasons why we don't have antibiotics in this region, for example, is not because of a lack of expertise. It's not because of a lack of need. The need is huge. It's not because of a lack of financing even. It's a lack of a road. The infrastructure is not there that allows for scientists to go through these steps. We got out of charity from lawyers like Isaac Rutenberg or Strathmore. They were the ones who really gave us a lot of charity at the start. And without being assisted like that, it was impossible. So I started thinking about how can you leverage on technology to try and make this easier? How can I make this process faster? Because by the time you're getting to the end stages of where now the antibiotic is ready for mass development to take it into the clinical trials, quite a bit of time had passed. So the patent has also lapsed. So this means the value of the patent is lower. So selling it or getting a partner to come on board to help you fund clinical trials, which cost billions of shillings, was a mountain that was just immense. And it's not like we have global goods within the field of antibiotics. There are not many research companies. So that's when I decided first to start my first digital health company. I wanted to see if I can teach people research using tools. So we had a very simple. That was the formation of my first company, my first digital health company. This is 2014, 2015, where we were like, how can I track? At that time, Bitcoin was just becoming, not Bitcoin, crypto was just, blockchain was just becoming a big thing. So we wanted, how can we use like the rigidity of the records that you have under blockchain to see if I can train people theory online. So we had a virtual academy online for research, and then now we take them through actual research and we track it. And then this became a bit difficult to do, so we just started with seeing, can I convert the research conversations, papers they're looking at, into a blog that the end users can come and meet. And that's when I met now my first game with adoption. Because you discover when you set up a company like that, you have to find ways to incentivize the healthcare workers to sit down and write and try to do this, and trying to do this without paying them.
Yeah.
Without paying them is quite hectic. Then on the other side, develop incentives for how do you get the end users, the patients at home, the clients at home, to come in on board a system. And I saw that is one of the conditions, that is, you're pulling on both sides, and if you have little finances, your runway becomes very difficult. In trying to solve this journey, trying to read around this journey, I bumped into an amazing human being called Prof. Tanya Douglas. I think this was at TED Arusha in 2016 as well. When we were discussing the topic, that's when she made me notice that some of these things it's not just things you do out of feeling. It's a field, there's a science behind it, it's an evidence-based area. And she introduced me to this course. It's as biomedical engineering. The course is called Health Innovation. So I was able to apply for the course. I got to the program. I applied for a scholarship. I got the scholarship through the Mandela Rhodes Foundation, who were also able to put me in touch with a very robust network of African scientists who we still interact with today and like-minded people.
Yeah.
And I moved to Cape Town for around 4 years, where I started now my formal training in digital health, where now I sit, which allowed me now to be able to sit comfortably at the intersection between the techies and the healthcare workers. That means I can enter a project at any point, be it the design phase. We did a lot of design thinking work, end user work. We did a lot of hours. We're able to really get shocked by the potential of digital health in transforming design. Then you come and you apply a lot of implementation science techniques. You do a lot of financial units to do business model designs for organizations, and then also rigid project management, technology management, and the whole shebang. And then the last bit of the course, the last bit of the competencies have to do with health technology evaluations, which is basically what I've been doing since then. So COVID, by the time COVID was coming, by the time the sector was coming to look at us and say, hey, digital health is a thing. We've been doing quite a bit of work in technology evaluations and different things until now. Then I worked in the counties where we were looking at how to introduce some of these capacities. That was some of the most difficult times in my life, because imagine the course I did was new. I think as a medic, as a healthcare worker, medic, I was the first one to graduate with this on the continent. So that means it's nice to say, but when you come to actual working and actual doing it, it's very difficult, because you're not only selling a new innovation in a software or a tool, but you're also selling a new course and a new way to package knowledge within the digital health field. But this went well because I was able to do a large study before that, where I assessed, like, what does the sector look like? How does knowledge move between the different players within, that time we're calling it e-health, in the public sector of Kenya. Ended up covering public sector and private sector. I assessed all the innovations that have been deployed from 2001, when we started our first implementation plan in 1999, but the first implementations began in 2001, and then all 2018. And it was very interesting, because I was looking for, why is knowledge not moving? Why don't I know what is being done in Kisumu by a different person? How can we make this the same thing? Because we have these cliches. We always say that the reason why the health is not being absorbed is because of low knowledge among the population, low knowledge among doctors, low knowledge among nurses and other healthcare workers. But we wanted to see, are there other things? The same thing with the infrastructure. Before I talked about antibiotics, are there other things in terms of how we've organized the system that are making it more difficult for people to work in the sector? And the results, amazing. The research is online. It's a huge document. It's online on the University of Cape Town website. So we was able to understand that if you track knowledge, you'll be able, one of the other things that comes out is you're able to track finances and the search for capacity are how our network is structured. So if you want to really spur the drive for innovation for the field to grow, you already have the keys in how to turn it. This research has really given opportunities, because I know it actually played a critical role in how I got to my current position. In my current position now, serving as a head of division for digital health within the Ministry of Health. This is the youngest division, because it was a decision that was formed very, very, very recently. So I'm the first head of division. The directorate is called the Directorate of Digital Health, Informatics, Research and Policy.
Yeah.
So we have 3 heads. We have a division head for informatics, a strong informatician. We have a division head for research and policy, someone who has very good experience in the field. And the 3 of us work under our director, who's Dr. Langat. And I think this team has been able to achieve quite a bit because of the synergy we have and the way the expertise comes in different ways for us to help us. Yeah.
Wow.
I think that's it. An intro bio.
I think this is the longest introduction I have ever had, and I'm really glad that you said all that.
I hope I've covered other gaps somewhere else.
You have, but oh my gosh, let me tell you, you have said quite a bit. So you've done quite a bit for yourself, eh? I didn't know all these other things. Hey, you've done quite a bit. I'm sitting, or rather, I am facing, greatness. So that's really amazing. So was this a dream that you had when you were, maybe in campus or growing? I don't know. Or is this your parents' dream? Our parents, sometimes we live vicariously through our parents. So is this something that, you thought about when you were, just going through school and all that, or this is something that you thought about much later on in life while you're in campus?
No, no, it's always been my journey. I
Yeah.
remember I remember even early on was a time it's been my I can say it's been my journey. I was exposed to computers pretty early. I
Yeah.
always knew always knew I always knew I want to be in a field. So I want to be working in a field that's fast evolving.
Mm-hmm.
One, I can have my thoughts by way of being, having influencing direction and how it goes. And in terms of building, the dream is to build really big businesses in the sector.
Yeah.
And the easiest way to do that is not to do that once the train has left, is to be talking with the driver before the train starts moving.
Yeah. I know you
So that
you've
was
talked
always,
to, yeah, sorry, go ahead.
no, no, I'm done, thanks.
Yeah. So I know you said why you're doing digital health, or why you're really, passionate about this particular sector. So why do you think that digital health is not being adopted as fast in Africa? Right? Let's talk about Africa. So why do you think it's not being adopted as fast? And yet I believe, and I'm sure you do as well, it is the solution to a lot of the challenges that the healthcare industry has.
It's a myriad of things.
Yeah.
It's a myriad of many things. For example, I dispute some, for example, the question. I think there are parts of digital health that have been adopted very, 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 very fast. If we think
Yeah.
about it for claims management, across the country, we've been using claims management for quite some time. If you go to
Hmm.
NHIF, you have your fingerprint scanners, we have our smart technologies, we have Slate from Savannah. Such solutions have been adopted very fast. And there's, like, for example, for Savannah Informatics, when they were starting off, they were able to publish some of their processes in the Harvard Business Review. If you read that document, you see that there's a beauty in how the challenge is finding the perfect fit of solution to problem, and then the value proposition in between. We have a lot of solutions that are currently being deployed across the country,
Hmm.
but who's paying for them? The business model has been quite a problem. The design has been a challenge. But if you go to particular sectors, like for example, if you go to a sector like, for example, the field of HIV and AIDS, which through PEPFAR has really, really, really pushed the agenda for digital health. The technologies that they wanted have really, really, really permeated in the sector. And even you've seen another layer of ML solutions, the early ML solutions that have really, really been well adopted in Kenya have been within that field. So I guess it's how we package it. It's how we come and we place it. But then in looking at that journey of how do you place these different things in the sector to be able for it to work, the challenge becomes that for a long time, government has not done its role. For a long time, private sector has been trying to do the role of government. If you go, for example, to the companies I have mentioned to you, the smarts and the slates of this country, if you look at their systems inside, they have their own, they've tried to build their own HIEs to run and help them. This is the health information exchange to allow them to have the data moving. So the same thing I said before about why I didn't work in the field of biomedical of biotechnology was because we didn't have the infrastructure, we didn't have the roads. So even if you build the best car, when it comes to this road, the end result will be like, this guy is not working. This guy is not working well. So I believe if government comes and places in place the parts we're doing in terms of building the Kenya Super Digital Highway, we should see a change in how the solutions are being adopted. Because our population is ready. We have a population with a median age of 19, and we've had
Hmm.
free primary education for 3 years. Most of this population know how to use a smartphone. They understand what USSD is. Just about for us now, once the government does its part, industry should come now and pile the solutions, and you'll see a change in the
Yeah.
adoption.
Yeah. Yeah, so for me, I'm actually speaking from experience because, I mean, one of the main challenges that we have in the healthcare space is access and affordability, right? And that's an area that we need to really, I believe, focus on because, a person needs to go to hospital and get basic services for, a small amount of money, but that's not happening right now. They are going to clinics and these health centers, but they're not providing quality services, right? So we all want to access quality services with affordable rates. So that's what I mean by the adoption is not there because this particular challenge is yet to be addressed to a certain extent that you don't feel like you have that burden as an individual to go to a hospital and pay this, crazy amounts of money, right? That's what I actually mean.
Okay.
Yeah.
That one has been a challenge. That one I can say there's a statement that was made by one of the presidential advisors to me the other day, where he told us where he said that one of the challenges we've had in terms of how we've approached healthcare has been siloed thinking. We want the patient to come to hospital and access commodities. So we focus on commodities by themselves, and then we say we fixed that, we pump a lot of money in that direction and say let's see how that is going. But that time we haven't really looked at how we are doing our health financing, because on the other side, our health financing has been a big issue. In this country, over only 25% of people have insurance, and this is an HIF plus the private insurances, which account for like 2%. The rest account for 25%. 75% of the people are paying out of pocket. That means you have a bad bill, you deep down in terms of socioeconomic classes, in terms of what we call CHE, and then you have this other side where you come to a facility and you find an unmotivated worker because they're not being paid well. Those things when they are not working together, they don't not work in silos. They work in concert to give you that feeling you have of not being able to access quality services. But when you come and put them together and you take a step back and you have a systemic thinking kind of view about the problem is working in concert to create the poor access problem, then the solution must also be working in concert. And that's one of the approaches I'm really hopeful about, the new UHC approach that the government has taken, where we're not looking at any one of them as individuals. We're looking at them as an interconnected thing. We're looking at health financing to provide access to quality care irrespective of the facility you are. We're looking at commodity security being there, even all the way from level 1 across to level 6, and then fixing the health financing. All of this interconnected by digital health. So we're not going to take the approach of we're going to fix this one, then we fix this one, then we fix this one, then we fix this one. We're going to just take them as one and push them up together. And I believe this model has a high probability of being very, very successful.
Yeah. Yeah. So I mean you're touching on all the good points. And I mean I was speaking to, or I had other guests, Peter Kanda and Team Theory, and they spoke about the digital health superhighway. And this is part of your legacy project, right? So are you the one who actually thought about it, or where did this thinking come from?
No. Projects like this usually are usually the work of it's incremental building over time.
Period of time.
We happen to be the lucky ones who are at the helm when we have a government that's really focused on how to do this, and they've invested in the capacity of how to do this. I think this is one of the first times where you're having digital health specialists sitting at the top of digital health, guiding the conversation. So the naming of the highway, yes, we can say that is us. But the Kenya Digital Highway, is actually a condensation for clarity and communication with the public of a document that is we signed into a policy document by the Ministry of Health called the Kenya Health Enterprise Architecture. So this is a document that describes how countries are supposed to build a HIE, and most of the ones in Africa come off the work of actually their team here in Rwanda, when they rolled out the HIA and were like, this model can work for government. So this is, if you go to Tanzania, if you go to Uganda, if you go to Rwanda, you go to even Zambia, at least the countries I've been able to work with this week to see their different models of HIA. It's more or less the same. What we'll be able to take credit for has been selling the idea to the rest of the country. For us, it's been an adoption conversation. For we have this architecture, we need the whole sector to come together to sit down and be able to engage it. And this is what we've done through the convergence workshops that we're able to attend. I think I saw you there. The convergence workshop, engagements with the sector, engagements with the leadership. Now to the point where now from the highest offices, we are discussing a very technical document called the Kenya Health Enterprise Architecture in a simplified visual model that everyone is able to see, understand, and even see how they fit in.
I'm really glad to hear that, the main stakeholders or major stakeholders are actually coming on board to have this conversation, because I mean, I was talking to again Peter and team, and even during that forum that we had, and I mentioned that we need to go beyond conversations because I mean, this is the healthcare space where this industry is really fragmented, and we have too many challenges, and I mean, it's time to stop, not necessarily stop the conversations, but go beyond the conversations and see some action behind it. And I'm really glad that people like yourselves and Dr. Tim and Peter are really, really doing everything possible to make sure that this thing actually comes to light. So, I mean, for a normal Kenyan who does not really understand what the digital health superhighway is, maybe explain it in a very simple term, or like a 2-year-old to a 2-year-old, what this will mean for an individual or a hospital or any stakeholder in this healthcare ecosystem.
Sure. I would gladly. I love talking about this topic. The topic I can keep it here for 1 hour just discussing particular.
Yeah.
So the Kenya Digital Superhighway is which is the best way to describe it. Kenya Digital Superhighway it's a model for how we are going to digitize care. Before we talk about it, maybe there's some pre-information that is important. For example, Kenya is changing again. The model has changed with the revolutionary acts that have been passed last week. Kenya is changing the approach to how we come to UHC. UHC will now be delivered through our units where we will all belong, and we'll all belong individually as guests in urban areas and rural areas. Will belong to what is called a primary care network. So a primary care network is basically 100 households where we are will be attached to one community health promoter. That community health promoter will be in a group of 10. That group of 10, we refer to them as a community health unit. And then community health units will be in a group of 6. Those 6, we call them the lower spokes. And then those 6 will be attached to either level 2 or level 3 facility, depending on proximity. And then we take 5 of those level 2 or level 3 facilities and we link all of them to one level 4 hub. And that creates a primary care network that serves around 150,000 to 200,000 people and has quite a few human beings. And this is how the model will be. Health financing will follow this model, commodities will follow this model, and HHRH will also follow this model. And then now digitization, we're coming to map the processes that are part of this model. So this is important to mention because the only way we do this is if government takes its role. So a nice way to say, what is a Kenya Digital Health Superhighway? Kenya Digital Superhighway, first of all, is government taking up its position, being very clear about what its mandate is. We're not here to compete with private sector in building applications. We're not here to compete with other players in providing different services or competing with other ministries in terms of what we're doing. We're here to really focus on our mandate. And what's the mandate of government? The mandate of government is to create an enabling environment that allows a patient journey to be completely mappable. What do I mean by that? The easiest way for me to describe it is, and what it will do for the Kenyan is to give just a walkthrough of our patient once they come into the sector. Let's call my patient Njeri, one of my favorite names. So when Njeri walks into a facility, and Njeri walks into the facility, by the time she's home, we'll have ways of reaching her last mile. This is through a patient portal, and also this is through the community health tools, and also just even WhatsApp bots to be able to have conversations with and say, my back is feeling this way, this is happening, let me visit the nearest facility. As soon as they hit the facility, the digital superhighway starts to work. Well, the digital superhighway has around eight shared services or 8 registries. These are services that only government controls, and this is what our cybersec will be like really robust to protect our data. So as soon as they come in, the first registry that kicks in is the client registry. The client registry is the one which helps us to uniquely identify, this is Rahel, this is Njeri who has walked in. Njeri Mgani, Njeri from this community health unit. And this one is actually linked to the Ministry of Interior and Citizen Services system called IPRS, which is the holder of the Huduma number. So it will allow us to be able to know uniquely, this is this person, this is this person's child. And then this is also how we'll be able to retrieve your record. As soon as you enter, you'll be uniquely identified. The second registry that kicks in is the one which tells you which facility am I visiting specifically, what services are supposed to be offered by this facility, what are they allowed to do and what are they not allowed to do. And this is the facility registry, which is already ready and it's up and running. majority of facilities have what we call the MFL codes. Then as soon as you go beyond that, you're able to identify, you come and you meet the nurse, you come and you meet the clinical officer, you come and meet the doctor, the lab technician, any healthcare worker you interact with at that particular point should also be able to be uniquely identified. So we also have the healthcare worker registry. And then after that, we come to what is being done to you. At the moment, systems don't communicate because one system speaking in French in terms of code language, the other one is speaking in terms of English, one is reading in terms of in Arabic, it's reading backwards, it's reading a sentence from back to front when you're supposed last time reading front to back. So when they're trying to exchange information, the information just hangs in the air. So you control this by implementing things that are called standards. And this is now what the function of what we call the National Health Data Dictionary, which says if we're calling hypertension across board to be called hypertension. One system will not call it HTN, one other one will not call it high blood pressure, all of it will call it hypertension. So if you're speaking English, we're all speaking English, and this is how the sentence format is supposed to be written. Then immediately after that, so this means that if you're able to know who you were when you came, we're able to know who saw you, we're able to know where you are seen, and we're able to speak in the same language. This means that I can itemize and I can have an invoice of your activities every time for everything that you're doing, and all this information will be stored in a shared health record. So these registries together in concert. It's quite a big project. It might sound like it's easy, and you actually won't even see them functioning for many people. Many people will see the hospital management information systems at the end, and they'll just see the applications on the phone, while the government system will be running in the back to ensure that as soon as you're seen, as soon as you're leaving the hospital, you get an SMS on your phone that tells you you have been seen, this is what was done, do you agree with this, approve. It immediately goes to now claims management. And this system is one which is going to allow us to be able to link it to the LMIS. So as soon as you're given paracetamol or Panadol in a facility, Canada should be able to have visibility that facility X in sub-county Y has dispensed this, and this means the county stocks have come down by this. We should start preparing how to have these orders in stock for them when they come for their refill. So this is the Kenya Digital Superhighway, the core of the center which allows this to happen. So the registries. Then on top of the registries, now you have the interoperability layer. This is a system. I'm not get technical. This is a system that allows for now this information to be shared in. When the HMIS at the facility wants to query who the patient is, they come and knock on the door of the interoperability layer. Interoperability layer says, "Who are you? Have you gone certification framework? Do we identify you? Yes, we identify you. What are you asking this?" It takes the request, goes into the government systems, assesses, gets the answer, gives it back to the system, and asks, "So do you want anything else?" So we also have that layer. And then now around it, we have a very robust layer of cybersecurity, just protecting and making sure that all our data as Kenyans is safe. Together, that's what we call the Kenya Digital Superhighway. And eventually, people don't focus on the highways too much. We have all the roads, but if the road has, what's the point of the highway? So now the country and they come and populate the whole sector of applications, which will be cars in this narrative.
Awesome. So, I mean, from a layman's perspective, so will that mean that we'll be operating on one system, or you will take all the systems and put them in one operational kind of, port, if I can call it that, and then it just acts as one? Like, in mature markets, the way they just have that one system, they use one system. Is it like that? Or the way you're saying the other systems will still exist, but they're just, getting information from a central place, so to speak?
We're pushing for a vendor agnostic sector because one of the things we don't want to do is we don't want to stifle the digital health sector. Digital health has a potential to generate for the country quite a bit of revenue. So we don't want to come and say, no, we're going to have one system. We want to spy and then control data protection centrally. The best example I can give for this is to use a metaphor in terms of our country. In our country, we have many people of different tribes. We don't come and say to people, if you're not of this tribe, you cannot come to country. All we say is when you're coming to conduct official business, the official language of business is English and Kiswahili. If you speak these two languages, you're able to conduct business with the country. So that's what we're doing. We're saying many systems can occur, but as engineers are developing them, make sure that when you're coming to do the official business of moving data around, you're speaking in the language the government has selected. This will allow any application working in the sector to be able to speak our language. And this is where now things like HL7 and smart guidelines really come in to help us determine what the English and Kiswahili of the machines and the code will be.
Yeah. So, I mean, like from the hospital perspective, hospitals will be able to share data across. So if a patient goes in, they don't need to come with, a bulky X-ray film or a report or all that. They can get that information from the system, or if they access the system, something like that, right?
The only thing I'll correct in that statement, which is a very beautiful and correct statement, is the tense. Patients are able to see their data. Last week, we launched the first smart PCR in Kericho, and that's what we're demonstrating to the Deputy President. Deputy President was able to go to a household of a patient, see the CHP doing their work. They inputted the information on the phone. It was referred. Then we enter the government cars and we go as fast as possible to the next center. And by the time we get to the next center, that record was already there, ready, waiting for this patient. Then we leave that level 2 facility, go as fast as possible to the next facility, and even before you arrive, the record was already there. So it's just a matter of scaling the implementation, but the change is it's not we'll be able to, is there are patients in Kenya right now who are already able to see their data moving within facilities in their county.
Oh, wow. Wait, this is interesting. So it started with public health facilities, right?
Yes.
Okay. Wow.
Public health facilities will obviously be the first ones to go, because they are completely under the purview and control of government. Then for the private sector, we're having conversations with them about how they're going to come in, but a lot of them are interested. I know quite a few who've already sent in their requests to have their systems integrated. Because again, this conversation has been going on for a long time. We talked to Peter. Peter is a lot of private sector is ready for ICD-11. In fact, many private sector players are already in ICD. We are waiting for NHIF to catch up and go to ICD-11. Then you'll see the whole sector just switching onto the language like that. Now the journey adoption that we're going to follow as we scale.
Yeah. So if I'm a patient, I just go to hospital and I tell them I've been to hospital X, so you get the data and then we go from there, right? That's what
when you're a patient, you come with your unique identifier, you come with your Maisha number, you come with your identification and say, hi, I've come to hospital. Once I put in the ID of Rahel, immediately the record comes and the health worker is the one who's saying, oh, I see you in this hospital on this day. The patient will have, we want this conversation of, ulipewa dawa gani last time, what we used to do as early medics, that we were seeing patients who don't remember what drugs they are. They've gone to a specialist, the medicine has been upgraded, then they come to you, they don't know which medicine it was, you take them back to their old medication that wasn't working, then you wonder, why is this patient not getting better? That era is about to pass.
Yeah. And for me as a patient, will I have access to that information like on my phone, on an app, my records?
Yes. Eventually, we'll have the patient portal, and the desire of the president is for every government service that is offered by any entity should be accessible to the platform. So the initial patient portal will be able to access it. You'll be able to access your record the same way you access your driving service history, your driving license history, your taxes should be able to be accessed through a centralized mechanism. Yes.
Yeah. So will there be another exercise for people to give in their info, or they will use the government system, right? Because I know we did the Huduma number thing and all that. So will we do another exercise for collection of information, or it will be collected at the point of contact at the hospital for the patient, that is?
I don't think we'll go through a registration exercise. I think a part of the country is already going through a registration exercise. I think I saw yesterday that PS Ambassador Bitok from Citizen Services changed the regulations in the law. So I know now we are moving towards the adoption of the Maisha number. But from what I understand, for you, your Maisha number will be your ID, and this will be what will link a lot of the other information. So I don't foresee a mass exercise. For example, if you know your child's unique identifier, you should be able to go to a hospital and input your data, and you'll be able to see from you have a birth certificate, for example, that you have a child, and then now you have this is a NOPI for your child. The conversation is not more registration, it's more how do I get you to know what your number is.
Yeah. So, I mean, allow me to be devil's advocate for a minute. So I can hear there's a lot of political goodwill, which I'm happy to hear about, right? And UHC was also like that, right? But UHC kind of failed. So, I mean, for you being the person at the helm, and I mean, you have your other colleagues, but you're the one who's pushing this agenda forward with all these stakeholders that you're having conversations with and all that. What would I mean, what would you tell me as a normal person, as a normal Kenyan who has seen the UHC agenda starting and failing, and then now there's this other thing that has started, and you want me to trust that this initiative will actually get to the, mile that it needs to get to, so that at the end of the day, it benefits me as an individual?
Two things. One is just review it's not failed once, it's failed twice. This is the third time it cannot be time. The mentality is robust. It doesn't matter how long it takes us to do this, it will be achieved. However, this time to believe lazima work.
Yeah.
So but then the other bit about it comes to how does government operate. For example, imagine we had the election coming in September. By September is when we had the new government coming in. The PSAs and the ministers were being appointed in December. The new structure of ministry was being approved in Feb. The new team was coming in April. So by the time I get into September, the government has only been working for a few years. And then now you go into the next few years of implementation. Usually, government usually has very short time for the painful work. Because the thing I've come to learn, even as a Kenyan myself, is we're not very patient with processes. So usually a government usually has a very short time to implement its agenda. And for example, like the last UHC, the challenge I can say is it took too long to realize its agenda. It took too long to pass bill. It took too long to put in the foundational thing that ensure permanence of activity. Such that when the previous government went into early elections by year 2.5, a lot of the funding starts to wane away. A lot of the enthusiasm dies. A lot of the early push disappears. So for this government, I can say I'm very, very proud that within 1 year, 1 month, for example, of coming into power, we managed to change 4 laws. And these 4 laws will allow us to be able to continue. Come rain, come shine. It doesn't matter which government comes next. A lot of the changes, like we had the previous government, which built a lot of hospitals, but then immediately the new government comes in, it was not laid in law. It was not designed to withstand the robust changes of our political environment, and it's been swept away. But now we have laws. These laws means the next team that comes in for the next 5 years, we're building on what we are building on, and the one for that and the one after that. And in Kenya, it's very difficult to repeal laws. So there are normally structures in terms of health system strengthening that we normally use to make sure that whatever you're doing today becomes implanted and becomes a permanent thing. Right now, for example, in digital health, we have all our documents. Whether Ryan is at the top or not, there's a guide for how this thing is supposed to be. It's supposed to be done. But the one that makes me confident that I think we're going to achieve this is what you say. Like there's a doctor, Dr. Getao, who made a comment where he said one of the things he's noticed is he feels very lucky to be working in healthcare this particular time. And what did he mean by lucky? He meant lucky in terms of we had always been prepared for this work for a long time. What we needed was just that right opportunity coming to meet. And the opportunity was having a president who's very young, who's very tech savvy, who understands technology. He doesn't want to hear these stories that it's going to take 2 years to do this. He's like, no, I understand these timelines. Why can't this be done in 3 months, and then you use the rest of the time to do this a bit, and you will implement this. And you've seen it's not just in healthcare where digitization is kind of popping off. It's happening there in finances. It's happening in agriculture. So we're not the only teams which are being pushed. The fiber is really being pushed at a rate that is not as the same as it was before. So the onus is on us. The onus is on us as healthcare workers. The onus is on us to prove the value proposition of this. The onus is on us to make systems that are permanent, that cannot be swept away. Because the reason USAID did not work before was not a lack of understanding of what it is. It was the mechanisms that were put down to try and achieve it. So now we put in some that are very permanent. I'm sure in the next 10 years in this country, you would see the struggle for UHC will be something we'll be talking about in the past, for like, how did we not have this forever?
I mean, Dr. Ryan, you're saying all the right things. So for me, it's just to hold on to this, because as I was telling Peter in the other episode, I'm cautiously optimistic because this has been preached to most of us, and, we accept it, and you want to, support what the government is doing, the current government is doing and all that. But we've seen all the things that have happened in the past. But I have hope. personally, I have a lot of hope because I mean, with people like yourselves and Dr. Tim and the rest of the people who are really putting a lot of work to make sure that this happens, I mean, there's a little bit of hope. So let's see. And I mean, all the best, right?
Let me ask, let me ask back to just
Please.
to for that hope. The approach we've taken is a stakeholder approach. All of us are doing this. It's not Ministry of Health which is achieving it. It's players within the health sector coming together to push and achieve this agenda. From past experience, hope, and being preached on, how is private sector, for example, how are the other stakeholders taking their learnings and molding them to come and help us as government move in this conversation? Because, for example, I've come from county, I wasn't involved in the previous one, but someone like someone have been there, you've been preached on before the processes. How can we condense some of those lessons that you've learned in the previous attempts to come and help to be fewer? That's one of the challenges I always give. I always give the stakeholder. We need to have, again, mechanisms for how knowledge is supposed to move. Because if someone has tried to implement, you've generated knowledge. We have to use that knowledge in this new implementation.
Definitely. I mean, it's just allowing participation. So I don't know if this is a closed committee where you guys have, a round table where you meet and discuss all these things. I think allowing public participation, and what I mean by public is just allowing anyone to come and participate in these conversations and to give their voice into what you guys are trying to do and allow criticism. Because, for government, and we love our government, but, sometimes they do not allow criticism because they want to be looked at as they're doing the right things. But if you allow that public participation in whatever way, I don't know in what way, I don't know if it's in forums or you will open up a place on the internet where people will put in their suggestions, I do not know. But you have to allow it, and you have to allow, or you have to accept that there will be a little bit of criticism, but what do you do with that criticism, right? And take the lessons and then move with that. That's what I believe will actually hopefully move this conversation forward. And then you get the buy-in, because you see, when you're allowing people to come into your circle and you're allowing people to actually give you some information, and you're having conversations, then there's that buying, like what we are doing right now, right? So when I put this out there, it's like when I put this out there, I'm hoping that people will actually understand what you guys are trying to do, because at the end of the day, because healthcare has been politicized for such a long time, but when we have people like yourself and all these other people who are doing this, and they're allowing conversations to happen openly, because let me tell you, Dr. Ryan, I would have never thought that a person from the ministry will actually sit down with me and do this. So this for me is a big thing. It's a door that has been opened. So I mean, the challenge, I'm throwing it back at you, and I'm telling you, like, if you open it up for participation, public participation, you learn a lot more, because people have a lot to say. It's just that they don't know where to say it. So when you meet people in these networking forums, that's when someone opens up to you and they tell you stuff. And even in meetings that I have, because I mean, I'm in this space and I'm in the investment space right now. So we are doing these rounds of funding for hospitals and things like that. And the things that they tell me, I'm like, are you serious, or am I in another world? So allow that participation, and you'll be shocked. Yeah, sure, and I will help you to host this conversation.
I'm very happy you flagged this. This is one of the mechanisms for how enable to move within the sector. Yeah. But I think if you look at the top, all the way from the top, if you look, for example, at the individual PSAs, their social media accounts, the PSAs Twitter accounts, the Ministry of Health Twitter and Facebook accounts, they post every day. I think they post like 4 or 5 different activities, so you can be able to know. We will see a lot of stakeholder engagement is occurring. But you're right, we have to really focus on knowledge dissemination as part of the core of the ministry. Because if a tree falls in the forest and no one hears it fall, did it really fall?
Exactly. Yeah. And I mean, you've talked about Twitter and all that. People normally look at Ministry of Health and these other people as very, it's almost elitist. Like, these people are just talking about certain conversations that I cannot even participate in. What am I going to say, like a normal person? So if you make it so less almost informal, and have those conversations, you will hear so much from these guys. So I mean, as I said, I am a willing and able servant. Please put me to use.
Thank you very much. Thank you for this. For the platform. I look forward to engaging with the comments, I guess.
Definitely. And thank you so much for being part of this. Thank you for finally, for us having this conversation. And I'm sure we'll have a lot more. And I know from the comments that we will get, there's someone out there I know who will definitely want to hear more from you. So let's do something about it. Yeah. So thank you so much and all the best.
Thank you very much.
Thank you.
All
right.